Hello, everybody, and welcome to your asynchronous lecture of the week. This board should look relatively similar to how both groups ended on Wednesday, the morning and the afternoon group. We were discussing the cellular response. So in our in-person lecture in both groups, we got through the vascular response, which ultimately resulted in vasodilation and increased vascular permeability. And then we started discussing the cellular response and how, with the increased blood being sent into this capillary bed, it raises the hydrostatic pressure, which allows fluid to leak out. But then the fluid leaving the vessel is much more dramatic than what you would expect simply with high hydrostatic pressure, because with the increased permeability of the blood vessel, you've opened up gaps in the endothelial cells that let the proteins come out. The proteins, when they can cross the membrane, no longer have that oncotic power, right? Because they can just take their fluid with them. And as soon as you open up the barrier of the capillary wall, there is a huge concentration gradient because there's way more proteins inside than outside. So they are going to want to fly out, take the fluid with them, which is why the steps of the vascular phase create an environment that allows an exudative fluid, a protein-rich fluid into the interstitial space. And then in both groups, we talked about how if fluid is leaving and cells are being left behind, that is going to concentrate the cellular content, right? The liquid is out and the cells are there. We're going to have a more viscous blood. So with increased viscosity, you slow the blood. In some case, you even get stasis. And so that is kind of the image we have here of the red blood cells all kind of stuck together. And that creates an environment that is very conducive to allowing white blood cells to leave the capillary. Okay, so the increased viscosity and stasis creates an environment that allows neutrophils to adhere. So in your capillary, you have a little white blood cell floating around. And in normal blood flow physiology, when there's no injury happening, blood is moving really fast to the tube, and most of the cellular elements are closer to the center than to the edges. So if blood was flying through here at normal speed with normal fluid, it would be very unlikely that a white blood cell could attach to an endothelial cell. But by slowing the flow down and taking the liquid away, it allows these white blood cells to bump into and hit and attach to the endothelial cells. And you can see I'm adding little white blood cells attached to the endothelial cells in a process known as margination. Margination is the neutrophils adhering to the margins of the capillary, attaching to the endothelial cells. And then kind of like tumbleweed flowing down an old dusty road, these white blood cells just kind of humble bumble roll along. They just kind of roll along as they go and attach and kind of move along, dunk-da-dunk-da-dunk, kind of rolling along in a process that is known as rolling. So that one's nice when the names really sound out kind of what they're doing. So first we get margination. Then as they roll along the endothelium, we get rolling. And eventually you get, basically like a solid wall of white blood cells. And that is called pavementing. Which again, I love this. I love these terms because they really kind of describe, right, laying down a layer of pavement. Basically, we've lined the endothelial cells with white blood cells. So at the start of this drawing, when we were in person, I kind of eliminated all of the other agents of the acute inflammatory response and just left behind these leukotrienes. And I said they're going to have an important part of the cellular story, and that is this chemotaxis. These are my little radio calls. Hello, hello, over this way. Come, come, come. They are chemotactic for the white blood cells. So we have slowed the blood flow down to allow the white blood cells to attach. They roll along until the whole inside layer of the endothelial cells is lined with white blood cells. But now leukotrienes are going to draw them out of the capillary. And it's not, it is a process because they don't really fit. They kind of have to squeeze, so you can kind of draw them like all misshapen, like squeezing their way through. They ooze and squeeze their way through until pop, we get white blood cells in the area where the damage is happening. These are our, right, primarily we're talking about neutrophils here. They're very good at phagocytosis. So the calling of leukotrienes has allowed the white blood cells to squeeze through the wall. And the fancy term for that is diapedesis, kind of walking across the wall. And then once they actually break through and make it to the interstitium, that is called emigration. So the steps of the vascular phase were necessary and important to create a landscape that allows this movement of white blood cells to happen. First, we vasodilated, so we delivered more blood flow to the area, which delivered more white blood cells because white blood cells are in blood. So if there's more blood, there's more white blood cells. Then you increase the permeability so that both fluid and proteins could leave, which dramatically drains the liquid out of the capillary, concentrating the cellular elements behind. Now you have a bunch of cells that are bumping and jamming into each other, and it's pushing them to the edges, and it jams the white blood cells up to the cracks of the capillary, and they can grab hold and they can attach to the endothelial cells, and they ultimately line the endothelial cells and then are drawn out of the capillary by the chemotactic call of leukotrienes. So I hopefully said a couple times in person, but the whole point of the acute inflammatory response is to deliver the white blood cells. So, like, yay, we did it. All right, let's go back to the PowerPoint slide. So here you can see kind of those exact steps of extravasation listed out here, where we first have margination, then rolling, adhesion or pavementing, and then eventually diapedesis and transmigration, where the white blood cell makes it through to do its job. And again, we are primarily talking about neutrophils. So their main job, and I love this picture because you can see them gobbling them up, is phagocytosis. So the process of phagocytosis, I've referred to several times, but kind of more in silly jargon than physiological terms. The neutrophil will engulf the foreign body, okay? So it will wrap its own membrane around it, and it will basically create what's called a phagosome. A phagosome is a membrane-bound body that has the foreign element inside of it. Now, at that point, inside of the cell, we have lysosomes. Lysosomes we talked about in cellular injury because it has all those digestive enzymes in it. Again, this is a membrane-bound sac because if the digestive enzymes were released, it would just kill the macrophage. So the lysosome fuses with the phagosome, and by doing that, it exposes the contents of the phagosome to the enzymes that will digest it. Then you merge your the phagolysosome now has a new name because it's become joined of the two. You kind of fuse that with the membrane to allow you to dump its internal contents out into the extracellular space. And all of this kind of soluble debris here can be helpful because little peptides that are spit out can actually be used to help develop antibodies against a foreign body. So this is the true full steps of the phagocytosis. Probably in lecture, I just referred to this as the big eater. This is what I was thinking about in my mind when I was talking about the big eater. But now you have the full steps in front of you. So The acute inflammation allowed a scenario where we delivered white blood cells that were capable of phagocytosis in order to set the stage for tissue repair. This is kind of a classic image of the 5 cardinal signs of inflammation. This gets very, very high on my list of things that are very important for you to walk away knowing from this class. We will diagnose inflammation. We will treat inflammation. We will try to induce inflammation in some cases in our PT practice. There's actually times when it's important to go in there and cause a brand new inflammation. It is critical that you understand the evidence of inflammation so that you know it when you see it, and it will match your expectation for whatever is the condition that you are treating. So we're going to go through these 5. I would feel very comfortable being able to specifically attach each of the signs of inflammation to specific steps in the inflammatory process. All right, the first is heat. I was going to do a graphic of heat, but I'll just leave the cartoon to do it. All right, so heat. Why is it hot? If someone has an acute inflammation and you put your hand in their skin, you will feel warmth. What is the source of that warmth? It's really twofold. One, we have done a ton of vasodilation, and our blood carries a lot of heat. So with increased blood in the area, you will increase the heat. So the vasodilation all by itself will increase the heat. It's more than just that, because once you deliver all of these cells and it starts undergoing phagocytosis and releasing cytokines, there is a ton of metabolic activity at the site of injury. And metabolism, anytime you undergo metabolism, there's a byproduct of heat, right? It's not a perfect transaction of stored energy to usable energy. We release heat in that process. So we also get heat from increased metabolic activity. All right, the next one is redness. He's a little red in the face for redness. Now this one we actually talked about already in class. We went through why it is red. It is not red because red blood cells have left the capillary and are now in the tissue. That would be a purple, blackish hematoma. It is rather pinkish red because of the vasodilation, right? The increased blood. So increased blood in the area, blood in area. You know, I think in both classes I used the example of vasodilating your cheeks. If you're running really hard or exercising really hard and your cheeks get pink because there's more blood in your surface blood vessels. Very similar here. At the site of acute inflammation, massive vasodilation increases the blood, it makes it red. And then on top of that, you have concentrated the blood in that area when all the fluid leaked out. And so you have increased viscosity and or stasis that can, stasis, let's see if I can erase that. That can contribute to the color. All right here in the middle, we've got swelling. Swelling. What steps are going to cause swelling? The process of the vascular phase increased hydrostatic pressure and allowed proteins to leak out. So the movement of fluid from the blood vessel into the interstitial space creates the swelling. So increased fluid. And if you had to say if that fluid was a transidate or an exudate, the fluid of acute inflammation has exiting proteins, so it is an exudate. All right, the next one is pain. The pain of inflammation. Let me see if I can get this guy over here. Now, let's think this one through. We haven't talked too much about this. In lecture, we talked about one agent of the inflammatory process that sensitizes pain receptors. Does that sound familiar? prostaglandin sensitized your pain receptors. So I'm going to put it down, but prostaglandin doesn't cause pain. It just makes your nociceptors more likely to fire, right? It lowers the threshold so that it's easier to get an action potential. So certainly prostaglandin contributes to pain. But what actually causes the pain itself? So we have the nociceptors. They're in the periphery. They need some kind of noxious stimulus in order to fire. What is the noxious stimulus? All that fluid that is leaked out into the periphery. This is not a little bit of fluid. Try to picture, a time in your life where you had an inflamed part of your body. And I feel like all the pictures that almost always get pulled up are like really bad hangnails, because that's such a good sight to think of that like pressurized fluid. Fluid that is in that space becomes pressurized because there's only so far your skin can stretch, and it will compress the nociceptors in that tissue. So the swelling compresses nerve endings. Compresses the nerve endings. So, for making sure we understand this clearly, if you were going to answer a question on what is the cause of the pain, what causes pain in acute inflammation, it would be swelling that compresses nerve endings. What, increases the pain or makes the pain worse or contributes to the amount of pain would be prostaglandin, because that sensitizes these nerve endings, that they don't need as much compression as normal to give you that fire, that shot to let you know that you are having pain. All right, the last one is loss of function, which is critically important in our world. This is probably what we actually measure and document and do outcome measures on. The loss of function is critical, but where does it come from? Which step of acute inflammation causes the loss of function? If you're picturing a patient in your mind who didn't want to move a joint because they're having an acute inflammation, no, don't touch me, don't touch me. Why are they not using that joint? They're not using the joint. They don't want you to touch them because they're in pain. Pain is going to limit function because pain is going to inhibit the activity. It will inhibit your drive to use that joint, your ability to participate in activities because you don't want to, but it also can actually inhibit muscular activity. There's feedback loops that try to protect your joints and actually inhibit muscle activation in response to pain. The other reason is it might not be able to move as far because, let's use the example of a joint again. If it's filled with fluid, it's going to take up all the space for joint movement. So the other reason that you lose function is because of the swelling. Pain and swelling is really the cause of the loss of function during acute inflammation. So as you are studying the steps of inflammation, I hope that you can tie it to two different ends of the story. One, can you say the how and the why is it important for fighting the infection, fighting the injury, preventing the injury, setting the stage for tissue repair? And what does it look like on the outside? What is the evidence, or how does this manifest itself in a way that I will see it as a PT on the outside of this body? I will feel the heat of the blood and the activity. I will see the redness of the blood and the viscosity. There'll be evidence of that swelling. And, that swelling kind of allowed the scenario to deliver all the white blood cells, but the swelling in and of itself actually does serve a purpose. The fluid that, comes into this area does help to wash out the invading microbes, the remnants that get spit out in the phagocytosis process, the cellular debris that's in the area. That swelling also serves an important purpose of a kind of a washout, clearing that tissue out as this repair, as the stage for repair is beginning to be set. It helps clear that out. So how the swelling got there, what the swelling does in terms of its ability to wash things out, but what does it do in terms of what it leaves behind, right? When you leave those cells behind, it creates the scenario for white blood cells to get out. Can you relate back the steps of that fluid moving out on the generation of pain, and then put it all together in terms of why that might prevent someone from using that part of their body normally during the acute inflammation? So this diagram is in your notes at the top of the next page, and this kind of titled with response to damaged tissue. And the first thing that happens is acute inflammation, which is what we have gone through here. If acute inflammation works, then the damaging stimulus is removed, right? That we vasodilate, we have a leaky vessel, we deliver the white blood cells, they chew it up, they spit it out, it all gets washed away in the fluid. The problem is done. And we've said, or I've said a couple of times now, this acute inflammatory response is setting the stage for tissue repair. So kind of what happens next? After acute inflammation, if the damaging stimulus is removed, you really have two choices. Number one, you can get tissue regeneration. Now, if you could pick, this is the one you want. You'll put a little heart here. Say, this is what we want to have happen. Tissue regeneration is the new growth of the cells that were lost in the injury. And why that is the best option is because if you can replace the cells that were lost, you get to restore both the structure of the tissue and the function, right? So with tissue regeneration, you get structure and you get function because the cells are back and the cells can do whatever job they were doing before. In order for tissue regeneration to happen, in order to recreate exactly what was there before, a couple things have to happen or have to be possible. One, you have to have cells left that can regenerate, right? You're going to need to have proliferation of cells that survive the injury. So if the injury is too severe, you might not have cells left behind to replicate. It also might not be a type of tissue that is even capable of that. So this chart is just below the figure under tissue regeneration. And it just talks about 3 different tissue types and their likelihood or their ability to regenerate. So the first is permanent tissue. And permanent tissue is terminally differentiated, meaning it's like all the way grown up. It is in its adult form. It has its full function. It knows who it is. And it's non-proliferative. It can't divide and grow. So examples of permanent tissue are neurons, cardiac and skeletal muscle cells. These cells are not able to regenerate. So if you get an injury in a permanent tissue, the end result would be a scar, not regeneration. So that's important to know for us. For those of you who are going into the neuro field, and well, everybody should probably know this, but injury to the brain is irreversible because it forms a scar. Injury to the heart is irreversible because it forms a scar. Now, I always want to just mention, a little asterisk here maybe, that there is some limited stem cell replication and differentiation that has been identified and published on that it can occur in the brain. There's some muscle cell proliferation. So it's easy to say in a slide like this that it does not regenerate, but obviously the shades of gray are infinite, and there is some limited ability to replicate. And that is incredibly exciting because this is the doorway to the future in terms of research that might be able to exploit this and maybe develop exactly the right stem cell cocktail that could actually cause true full regeneration. So I don't want to diminish the fact that you might have read that somewhere or that it's been published. It is certainly true that there has been some evidence to show that this is possible. But in clinical medicine, in the human beings that you will see, even if some regeneration is happening naturally, it is insufficient to produce tissue regeneration after injury. So I just don't want you to, be like, I read somewhere that it can replicate. That is hopefully, a little tiny bit true. Like that is going to give us a chance to get treatments and gene therapies and drug therapies that might actually just change these injuries in the future. But right now, physiologically, these cells in response to an injury will scar. So the scar will dominate, and then we're just hopeful for what, the scientists can do to exploit the potential for regeneration. That's very, very exciting. All right, labile tissues, number 2. Easily altered or changed tissues. So they contain abundant stem cells. They're normally continuously turning over. So this is our surface epithelium, bone marrow. These cells can definitely regenerate. The last one is stable tissues. So stable tissues are normally quiescent, meaning not dividing, but an injury can lead to some cell proliferation. So we talked about this with the liver, and some other solid tissues have this. Smooth muscle has the ability to, in some cases, regenerate. So we said that the ultimate goal would be to have tissue regeneration because you get both the structure and the function of the tissue that you lost. If tissue regeneration is not possible, the cell will respond with fibrous repair. That's fancy for scar, right? It's going to lay down fibrotic tissue. And this is good because a scar can restore the structure. It can hold two ends of a wound together. It can go down into your tendon and replace the missing piece, if that's, an example. You can get the structure back, but you will lose the function of whatever those cells had before because it's just a scar, a non-functional scar. So it's not ideal, but it's great because you'll be able to put the tissue back together and then you can go on your merry way and hopefully the cells around it can make up for the loss. So when acute inflammation works and the damaging stimulus is removed, you either get regeneration or a scar. If the damaging stimulus is not removed, and we'll talk about in kind of below in your notes, we give some examples of chronic inflammation. But if the stimulus isn't removed, either because it can't be, or it's too severe, or it's autoimmune, so it's a tissue that's supposed to be there, so it's going to keep triggering your body over and over again to attack it. Whatever the case is, you can move into chronic inflammation. So chronic inflammation is inflammation that lasts more than 2 weeks. So in general, acute inflammation should be able to get the job done in less than 2 weeks. It should be able to remove the damaging stimulus. If you are still having an inflammatory process beyond 2 weeks, you are now in chronic inflammation. The really negative thing about chronic inflammation is that, in acute inflammation, normally, those cells that come in do some damage. They chew up tissue, they break cells down. We kind of talked about some of those white blood cells having enzymes that degrade tissue, and that can weaken the area and cause some tissue damage. But acute inflammation comes in, causes some damage, gets rid of the stimulus, but then it's done, it goes away, and it allows repair to happen. In chronic inflammation, there's still tissue injury happening. The damage of all the white blood cells that are on the scene is continuing to occur, but it's also trying to repair. So damage and tissue repair is happening at the same time. And this is not sustainable to make any kind of positive impact on the tissue because you can't break it down and build it at the same time. Now, it's important to note that a healthy immune system usually doesn't turn chronic. That's not a normal response. But if you can't get rid of the microbe, or you can't stop having the same stimulus happening over and over again, then it can turn chronic. So I just included a couple causes of chronic inflammation to include in your notes. Persistent infections that we have a really hard time killing off. There is a whole host of immune-mediated inflammatory disease, a lot of autoimmune, and then, prolonged exposure to certain toxins can all lead to this chronic inflammatory state. And the cellular processes of chronic inflammation is very different than acute inflammation. So, chronic inflammation can arise spontaneously, but a lot of times it comes kind of following a bout of acute inflammation that didn't do the job. So the scene kind of had been set, but they didn't get the job done. They didn't remove the damaging stimulus. So let's just look at the cells on this screen because it kind of gives you an idea of what you might see in the interstitium at a tissue that's experiencing chronic inflammation. First, you're going to see macrophages. So macrophages are those cells that, it's a monocyte that has left the blood vessel, and it has a very long life. It can live from months to years in the interstitial space before it is dead. So the presence of macrophages is a common finding in chronic inflammation. You also see lymphocytes, which is very unique because those cells take longer to get to the scene. So it's unlikely you'd see lymphocytes in acute inflammation, at least not, initially in those first couple of days. But here they've had time to get produced and they're ready to go. So we've got lymphocytes on the scene. We have both T cells and B cells. B cells obviously want to be somebody else. So you can also have plasma cells in the scene, which are now producing antibodies. If you look at the white blood cells, you can see that we have cells that were called to the scene during the acute inflammation, and they're still hanging around. Okay, so we've got these immune cells that just haven't left. If you compare this to what you'd see in acute inflammation, a really big cell is missing. Neutrophils are the primary white blood cell of acute inflammation, but a neutrophil only lives a day or two once it is outside of the blood vessel and in the tissue. So they die off pretty quick. And the chronic inflammation is left to the macrophages and the lymphocytes. So let's go through. If you want to turn the page, I have this full animated diagram kind of in your notes. You'll see the steps listed above it. But chronic inflammation is considered a T cell mediated response, in that during chronic inflammation, T cells activate macrophages. If you remember, T cells had the ability to release cytokines that act on other cells. So T cells activate macrophages, which then release growth factors. So macrophages, activated macrophages, start pumping out growth factors, which go over to the fibroblasts and cause fibroblast proliferation. Okay, so in the live lecture, I talked up the fibroblasts. I think I kind of gave you a little you-rah-rah to the fibroblasts and talked about how we often try to stimulate them and they're this great guy for healing. Everything in moderation, right? Now we're in a state of chronic inflammation and we're overactivating, calling extra fibroblasts to the scene. So they're going to proliferate. And what do fibroblasts do? They lay collagen. So we're going to see excessive amounts of collagen laid down in chronic inflammation. And this is problematic because we're still causing the damage with the white blood cells. So this is where damage and repair is trying to happen at the same time, and it is insufficient and stuck in this repetitive cycle. The other thing that the growth factors released from activated macrophages can do is stimulate angiogenesis. Angiogenesis is the growth of new blood vessels. I always, the way I remember things, I always kind of think of everything as a story. And so I often think of what is the tissue thinking right now? What are they thinking? Well, if you can't heal something over and over and over again, what could you do to fix it? Wouldn't it make sense to think, if I could just get more blood delivered to this area, I think it would fix the problem. So macrophages can't think, but if you pretend they could, you could see them trying to solve the problem by growing new blood vessels. If you have more blood vessels, you can deliver more blood to an area. Unfortunately, it doesn't fix the problem in most cases, and we just see the growth of new blood vessels. In addition, we have the B lymphocytes, which have differentiated into plasma cells. They're producing antibodies. The antibodies are coding. If there is a bacteria there, it's still trying to manage the phagocytosis of that microbe. It's just insufficient, and that is why we're stuck in chronic inflammation. So this is just sort of a cellular overview of the chronic inflammatory state. You guys are obviously going to get a ton of information on chronic inflammation and chronic pain syndromes when you get to your pain class. But I just want to kind of put it in context. You can think of this when you compare it to acute inflammation and how different these steps are and how less effective it is at really getting any single job done. It's kind of a mess. All right, we have gotten through the inflammatory process. So we have completed the cellular injury, adaptation and injury, all the way to irreversible cell death. We have discussed the processes that when there's tissue injury, how the body responds with acute inflammation. This is the end of this series. And so I'm going to end the lecture here and do the second half of the video on the beginning of the laboratory values and the blood disorders, which is in your next packet. So you can end it here. The second video of this series will be a little longer since I'm at about the 36-minute mark here. And we'll try to round it out at that 2-hour mark in the next video. Thank you for your attention.